You know that sound? A ventilator alarm goes off. It's got to be one of the most stressful sounds in all of critical care, right? Well, this explainer is all about giving you a practical guide to cut right through that noise. We're going to help you think clearly and act decisively when every single second counts.
Okay, so picture this. You're in a super busy ICU, right? You've got a critically ill patient on the vent, and bam, that piercing alarm just cuts through all the chaos. And what happens? Every single eye in the room turns to you. The big question is, what's your first move?
All right, before we dive into troubleshooting any specific alarm, we have got to lay down the golden rule. Here it is. Check the patient first, check the equipment second. Look, equipment problems, we can almost always fix those, but a missed patient crisis, that can be absolutely catastrophic. So if you remember nothing else, remember this. Always, always focus on the person, not the machine.
Okay, let's kick things off with probably the most common alarm you're going to hear, the high-pressure alarm. The easiest way to think about this is that the ventilator is basically screaming at you, hey, I'm meeting way too much resistance trying to push this air into the lungs. So our job becomes a bit of a detective mission. Find out what's causing that blockage.
So right away, you're at a fork in the road. A high-pressure alarm means you're dealing with one of two core problems. Is it a patient problem or is it an equipment problem? Is the resistance coming from the patient's body, a change in their lung condition, or is it something much simpler, like a mechanical issue with the vent circuit? We have to figure out which path to go down, and we have to do it fast.
So what's the very first thing you do? You look at the patient's blood pressure. High airway pressure combined with low blood pressure, that is a massive red flag. It's a killer combo that points to two immediate life threats, something called autopeep or attention pneumothorax. And why is that so dangerous? Well, because both of these conditions can physically squeeze the heart and the major blood vessels, and that stops blood from getting around the body. It's a huge deal.
Let's talk about that first one, autopeep. Take a look at this waveform. See how that expiratory flow line, it never gets back down to the baseline to zero before the next breath starts? That is your classic visual clue. It means the patient isn't getting all the air out. They're not fully exhaling. So air gets trapped, the pressure inside the chest builds and builds, and it can, quite literally, crush the blood vessels in the chest. Really, really dangerous stuff.
Okay, and what about that other immediate life threat? That's attention pneumothorax. You have got to rule this out. So what is it? Basically, a lung injury creates a kind of one-way valve. Air gets in, but it can't get out. So with every single breath a ventilator pushes in, more and more air gets trapped in the chest cavity, building up pressure.
And this image, wow, it just perfectly illustrates how dangerous this is. On the left, you see a normal chest x-ray. But look at the one on the right. The lung is totally collapsed. And see how the heart and the windpipe, the trachea, are literally being shoved over to the other side? This is a true clinical emergency. It needs immediate needle decompression. You absolutely cannot wait for an x-ray if your patient is unstable.
All right, now let's say your patient is stable. Their blood pressure is fine. Phew, the cause is probably something much, much simpler. This is when we start hunting for those basic equipment issues. Is the tubing kinked somewhere? Is there a bunch of water condensed in the line? Or maybe, just maybe, the endotracheal tube is clogged up and just needs a good suctioning.
Okay, let's switch gears to the second big alarm you'll run into, the low volume alarm. You might also hear it called the low exhaled tidal volume alarm. This one is asking a totally different question. The ventilator is saying, hey, I pushed a specific amount of air in, but I didn't get it all back. So where did the air go? This is all about a search for a leak.
And guess what? Just like with the high-pressure alarm, we're back at that same fork in the road. We have two main pathways to explore. Is the air leaking out somewhere in the equipment, the ventilator circuit? Or is the leak happening in the patient or maybe around the breathing tube itself?
Now, a leak inside the patient can be super serious. We're talking a pneumothorax again. But honestly, the most common culprit by far is a simple cuff leak. You know that little balloon at the end of the breathing tube? If it's not inflated enough, air can just sneak right past it and escape back up the throat instead of going down into the lungs where it belongs.
The good news is, fixing a cuff leak is usually pretty straightforward. A lot of the time you can actually hear it. It sounds kind of like a gurgling noise up near the patient's neck. All you got to do is grab a manometer, check that cuff pressure, and then reinflate it to the right level, which is usually somewhere between 20 and 30 millimeters of mercury.
Okay, so what if it's not a cuff leak? Well, now it's time to go on a hunt for an equipment leak. And the best, most effective way to do this is to get your hands on the circuit. Start right where the tube connects to your patient and physically trace the tubing all the way back. Feel every connection point, every seal, until you're right back at the ventilator itself.
So you might be thinking, how on earth am I supposed to remember all of this in a high-stress crisis? Well, that's where a good mnemonic comes in. The one you need to know, the most common and effective one for any ventilator alarm, is DOPE. Think of it as your rapid, systematic checklist you can just run through right there at the bedside.
All right, let's break it down. D is for displacement. First things first, you have to confirm that the endotracheal tube is actually where it's supposed to be, in the trachea. Because if it's been pulled back into the esophagus, well, you're just pumping air into the stomach. No good. And if it's pushed too far down into one lung, the other one isn't getting any air at all.
Next up, O is for obstruction. Simple enough. You're looking for any kind of blockage. Is the tube kinked? Is it totally gunked up with secretions that you need to suction out? Or is the obstruction coming from the patient themselves? Are they having a bronchospasm, like a severe asthma attack that's clamping their airways shut?
Then we have P for pneumothorax. Yes, again. This one is so critical that it gets its very own letter in the mnemonic. You always have to ask yourself, has my patient developed a collapsed lung?
And finally, E is for equipment. This is kind of your catch-all for any machine problems. Go back to basics. Is the ventilator itself actually working? Is it plugged in? Is the oxygen tank connected and, not empty? Have you double-checked that entire circuit for leaks or any disconnections? The simple stuff.
All right, so we've covered high-pressure alarms, low-volume alarms, and we've got our DOPE mnemonic in our back pocket. Now, let's put it all together. What's your immediate action plan when that alarm starts blaring?
Okay, if there's one single thing you take away from this, let it be this. If you are ever in doubt, or if your patient is unstable, disconnect them from the ventilator and start bagging them by hand with a bag valve mask. This one move immediately tells you if it's a patient problem or an equipment problem. Plus, you can literally feel their lungs with your own hands. From there, you just systematically run through DOPE, and never forget the simple rules. High pressure equals resistance. Low volume equals a leak. Look, it's really not a matter of if you're going to face this situation, it's a matter of when. So the next time that alarm goes off, you're not going to panic. You're going to have a system. You know the golden rule. So let me ask you one last time, what's your first move?